Have you ever introduced, a brilliant new idea, some cutting-edge tech, or even just a simple efficiency tweak only to hit a wall? Like totally unexpected resistance.
Oh, absolutely. Happens all the time.
And you think, okay, maybe it's the functionality, or maybe they need more training, maybe it's just a learning curve.
Right. The usual suspects.
But what if it's something deeper? What if we're missing the human side of it all? The subjective stuff.
Exactly. And that's kind of the territory we're exploring today.
Yeah. Our mission for this deep dive is to look at this really fascinating, maybe a bit overlooked research technique that gives us a unique shortcut to understanding that human element in adoption and resistance. It's called Q methodology.
Q methodology, not exactly a dinner party topic maybe, but incredibly clever.
Right. And it offers this unique lens on why people react the way they do. We're going to unpack it, really get into how it works.
And our guide here is a really insightful paper, actually from back in 1997, from the Journal of the American Medical Informatics Association.
That's right. Q methodology, definition and application in healthcare informatics by Valenta and Wigger.
Even though it's from 97, the insights, especially around healthcare IT, are still so relevant.
Totally. So we're going to break down this approach, see how it uncovered some surprising things about why healthcare pros accept or resist new tech, and importantly, what that means for anyone, really, trying to introduce change.
Sounds good. Where do we start?
Okay, let's unpack the problem Q methodology actually solves. Traditional surveys, the multiple choice, like Kurt scale kind.
Yeah, the ones we all get bombarded with.
Exactly. They often just give you this single composite average opinion. The paper points out this average is often not useful for understanding the real range of concerns within a group.
Right. It kind of averages out the differences, doesn't it? You might find, say, 60% agree with something, but you lose why different people agree or the nuances in their agreement.
Yeah, the source says those methods can treat individuals as irrelevant except insofar as they provide the sources of variables. You get the big picture maybe, but you lose all the rich detail, the different ways people combine ideas.
And that's precisely the gap Q methodology steps into. It's explicitly designed, as the paper puts it, for the systematic study of subjectivity.
Subjectivity, that's the key word.
Definitely. It's this unique blend of qualitative and quantitative techniques. Its whole aim is to identify, categorize, and understand opinions, revealing these dimensions of subjective phenomena from a perspective intrinsic to the individual.
So getting inside their heads, basically.
In a systematic way, yeah. It's got history, too, developed back in the 1930s by William Stevenson, who is, interestingly, a British physicist and psychologist.
Huh. Physics and psychology, that's quite a mix.
It is, and maybe hints at its unique structure.
So how does it work? It's not just ticking boxes, right?
No, not at all. It's quite hands-on. First, researchers gather what's called a concourse of opinions. Think of it like gathering every possible statement or viewpoint on a topic from interviews, articles, focus groups, anywhere people express opinions.
Okay, like a big opinion soup.
Kind of. Then, from that huge pool, they carefully select a representative subset, the Q sample, usually around, say, 30 to 60 statements. The study we're looking at used 30. These statements need to cover the full range of the debate.
All right, so you have your key opinion statements, then what?
Then comes the Q sorting. Participants get these statements, maybe on cards, and they have to rank order them, usually along a scale like most agree to most disagree.
Okay, ranking seems simple enough.
But here's the clever part. They sort them onto an answer sheet or a grid that forces a quasi-normal distribution, like a bell curve.
Meaning?
Meaning they can only put a very few statements in the most agree pile and only a few in the most disagree pile. Most statements have to fall somewhere in the middle, the less intense agreement or disagreement zones.
I see. So you can't just strongly agree with everything. You have to make tough choices about what really matters most to you.
Exactly. It forces prioritization. It makes every placement meaningful. And then the sorted data gets analyzed using by-person factor analysis.
By person. Okay, that sounds different.
It's the absolute core of Q. Instead of grouping variables or questions that correlate, it groups the people.
So it finds people who sorted the statements in a similar pattern.
Precisely.
Yeah.
It identifies clusters of individuals who share a similar viewpoint, a similar way of structuring their thoughts on the topic. It reveals distinct types of opinion.
That is different. So it's not about counting how many people hold opinion X.
No, not primarily. The goal isn't to say 30% of doctors think this. It's to uncover different patterns of thought, to identify the kinds of viewpoints that exist within the group, regardless of how common they are in the wider population.
Which explains why you don't need huge sample sizes, right?
Exactly. You're not aiming for statistical generalizability in the traditional sense. You're aiming for depth, for understanding the structure of subjectivity. You want to find the main stories or perspectives that are out there.
Okay, that makes sense. It's about the quality and structure of opinions, not just the quantity.
You got it.
So that's the theory. How did this play out in the healthcare IT study from the paper? It seems like a perfect test case.
It really was. Even back in the 90s, the paper highlights this ongoing physician reluctance in the use of information technology.
And the concerns sound so familiar, don't they? Privacy, confidentiality, security.
Also worries about dehumanizing and depersonalizing effects, and this fear of unwanted accountability being monitored through the system.
Yeah, things we still grapple with today. It's fundamentally a human challenge, isn't it?
Absolutely. So this study dove right in. They surveyed 34 physicians and 25 medical students in the Chicago area.
And their goal was to understand the reasons for acceptance or resistance, to get beyond the surface level.
Yes, to understand the nuances, the different flavors of acceptance and resistance to these new information technologies hitting the workplace.
Okay, so here's where it gets really interesting, I think. They didn't just find pro-tech and anti-tech. They found 6 distinct types of opinion.
6, which is way more nuanced than the single average opinion you'd get from a standard survey. It shows the power of looking for patterns, not just averages.
Right. So what were these 6 types? Can you walk us through them?
Sure. They paint a really vivid picture. First, you had the full-range adopters.
The enthusiasts.
Pretty much. They saw potential everywhere, believed systems would improve patient care, and importantly, did not display any concerns. They were ready to use IT for everything from patient records to research. Your ideal early adopters, maybe.
Okay, makes sense. Who was next?
Then, interestingly, came the skills-concerned adopters. These folks actually saw a similar range of positive uses as the first group. But they had this nagging insecurity about their computer skills. They literally agreed with statements like, "I wonder whether I could ever take full advantage of computers."
So the barrier wasn't the value of the tech, it was their personal confidence in using it. That's a key distinction.
A huge distinction. It tells you the intervention needed is likely training or support, not persuasion about the benefits.
Okay, so 2 types of adopters, but with different underlying feelings. What about those who are more cautious or resistant?
Right. Group 3 was the technology-critical adopters. Like the others, they saw uses, but they had significant worries, specifically about record confidentiality and computer monitoring of their own actions.
So trust and privacy were big flags for them.
Huge flags. They strongly agreed that confidentiality and security were bigger problems with computers versus paper. The concern wasn't usability, it was about fundamental principles being potentially compromised by the tech.
Principles like confidentiality and maybe professional autonomy too.
Exactly. Which leads nicely into the fourth group, the independently minded and concerned.
Okay, what defined them?
Their focus was a bit different. They really emphasized using tech for literature access, personal research, alongside some office functions. But they shared concerns about confidentiality, their own skills, and being monitored.
So similar concerns, but maybe a different emphasis on use.
Yes, and their overall profile, the researchers noted, stressed things like the special nature of medical knowledge, the importance of the doctor-patient relationship, and crucially, professional autonomy and self-regulation.
Wow. So for them, the technology potentially clashed with their very identity and philosophy as a doctor.
It seems that way. The concerns were deeply woven into their professional ethos.
This is fascinating. Okay, 2 more types. I'm guessing these might be the most skeptical.
You could say that. Fifth, we have the inexperienced and worried.
Doesn't sound too positive.
No. This group saw a few benefits overall, and they worried about pretty much everything. Being monitored, confidentiality, security, their own skills, depersonalization, and the risk of overstandardizing medical care.
A whole laundry list of concerns.
Exactly, and the underlying theme. The paper says their profile revealed worries about threats to professional autonomy, and even the degrading of medicine from a profession to a technical occupation.
Wow. That's fundamental resistance. Seeing the tech as undermining the very essence of their profession.
It's a powerful perspective. And finally, the sixth group, the business-minded and adaptive.
Okay, adaptive sounds a bit different.
It was. Their focus wasn't so much on clinical enhancement, but on the business side. They emphasized using tech for things like checking patient eligibility data, keeping track of insurer rules and regulations.
So more about navigating the changing healthcare business landscape.
Precisely. They saw computer records as essential to compete with HMO and other business contracts. It was almost a defensive adoption. Their concerns were also different, more about things like vendor manipulation, confidentiality, and how time-consuming it might be.
So a pragmatic, almost reluctant adaptation driven by external pressures with its own set of worries.
You've got it. 6 distinct types, each with a coherent, internally consistent viewpoint.
It's just incredible how Q methodology teased out these specific viewpoints that would have been totally lost in an average score. So, okay, what's the big takeaway here? Why is knowing these types so much more powerful than just knowing the average opinion?
This, for me, is the absolute core finding of the paper. This study concluded that these different opinions were more closely related to their medical practice philosophy than to systems functionalities.
Say that again. More related to their philosophy.
Yes. Their underlying beliefs about what medicine is, about the doctor-patient relationship, about professional autonomy, those were bigger drivers of their reaction to IT than the specific features or usability of the software itself.
So physician resistance might not even be about the technology, really.
Often, it seems, it's directed at the underlying healthcare ideology driving the technology. Maybe the tech represents a shift towards more standardized, business-driven, or monitored care that clashes with their core professional values.
That completely reframes how you'd approach resistance, doesn't it? You can't just fix it with better training or a slicker interface if the root issue is philosophical.
Exactly. It suggests the problem might be much deeper, touching on culture, values, and professional identity.
Did the paper mention how this understanding was actually used? Like, the hospital involved do anything with these findings?
They did. The University of Illinois at Chicago Medical Center, where some of this research took place, used these findings to sensitize their implementation team for a new clinical information system.
Sensitize them. How?
Instead of a generic rollout, they created a flexible mix of classroom, customized, and individualized training interventions. They recognized that different groups needed different approaches, addressing not just skills, but also the underlying concerns and motivations revealed by the Q-sort types.
That's brilliant, tailoring the approach based on understanding the subjective viewpoint.
And think about the strategic implications. The paper suggests, for instance, that those highly respected full-range adopters, they could be recruited as system champions.
Right, to help persuade their more reluctant colleagues.
Exactly. Maybe someone like a technology-critical adopter addressing their specific concerns from a peer perspective.
And for the really resistant groups, like the inexperienced and worried.
Well, the paper points out that their resistance might require motivational interventions that are beyond the reach and jurisdiction of information systems departments.
Meaning it's not an IT problem to solve alone.
Right. It might require broader organizational change, leadership communication, addressing those deeper philosophical concerns about the direction of healthcare, maybe involving medical leadership directly.
This really brings it home. Whenever we're trying to implement something new, any new system or idea, it really is people who determine if it succeeds.
Always.
And understanding their subjective viewpoint, their why, using something like Q methodology, seems like it could unlock much more effective strategies than just focusing on the what.
It moves beyond just features and functions to the human core of change.
I know I've definitely been in situations trying to push an idea, thinking it's perfectly logical, and just hitting that invisible wall, not really grasping what was truly driving the hesitation. This gives a framework for potentially seeing behind that wall.
Yeah, it provides a map to that hidden subjective territory.
So let's just quickly recap. Q methodology gives us this powerful way to systematically study subjectivity. It moves beyond simple averages to uncover the diverse, structured patterns of opinion that exist within a group.
We saw how it identified those 6 distinct physician viewpoints on health IT, the full-range adopters, the skills concerned, technology critical, independently minded, inexperienced and worried, and the business-minded.
And the crucial insight. Resistance often wasn't just about the tech itself, but about deeper clashes with their medical practice philosophy.
Which really raises a critical question for all of us, doesn't it?
Which is,
How often do we encounter what we label as resistance and just dismiss it? Maybe as stubbornness or lack of understanding or laziness? When really, it might be rooted in a deeply held personal or professional belief system, a philosophy that the change or the ideology behind the change fundamentally challenges.
it's easy to miss that complexity if you're not looking for it.
Very easy. This methodology forces us to see that richness.
So maybe a final thought for everyone listening. The next time you run into resistance, at work, in your community, maybe even at home, pause for a second.
Ask yourself, am I really trying to understand the subjective experience here? Is there a hidden medical practice philosophy, or whatever the equivalent is in that context, shaping their view?
It might not just be about the specific proposal, the what. It could be much more about the why from their perspective
Yeah.
and how this change fits or doesn't fit into their world, their values, their story.
Getting curious about that subjective why could change everything.